Good morning. My name's Maxine Power. I have the huge privilege today of talking to you about a programme of work that I've been involved in for the last 3 years, and hopefully at the back you can see that here what we've got is a timeline. So I'm going to, in just under 20 minutes, take you on a bit of a whistle-stop tour of what I and thousands of others in NHS England have been doing to try to sort of operationalise some of the safety measures into the system. And what I'm going to do is I'm going to actually provide you not with the glossy brochure version of this. I'm going to provide you the real live version of it, because I actually believe that that's how we'll move forward. So I'm going to show you some of the things we've done and some of the things we've learnt, and hopefully that will give us an opportunity to have a conversation and to take things away that are new and interesting. So let's pursue this. So just safety thermometer. So the hints in the title. This is a bit of a temperature check. So when you look at the work that Jonathan's just presented, absolutely fantastic. I mean, I'm a governor of the Health Foundation and they are doing some amazing work. And that gives you a broad framework. And I'm sort of going from that broad framework here to a tiny piece of the action. And there's one thing that we really need to keep in mind when I'm talking about trying to establish a temperature check on a system as large as NHS England. So I was just looking at the attendance list for this session, and you know, we've really got delegates from all over the world. I'm quite interested in people taking what we've learned at the national level and applying it to whatever level of the system they happen to be working at. But I think Jonathan said context matters. And for me, when we started to think about this work, and for the steering group that I work with, context really mattered. So in 2010, it became apparent to the leadership of the NHS that we have big challenges in terms of the sustainability of our healthcare system. So we know we've got a population that's living longer. We have new technologies and new medicines that are costing us more and more and more money. The revenue, the spend on the NHS had been increasing by roughly 6% year on year. So in England, we spend £100 billion on our healthcare system. And we knew that in order to be able to do more with less money, we really had to drive forward improvements in system redesign and in the quality of clinical care. So a programme was launched called CQUIN, which stands for Quality, Innovation, Productivity and Prevention. And it was a large-scale change programme launched by the Department of Health and supported by the government in 2010, which had an initial ignition phase, which was a programme of national work linked to regional work and local work. And the bit of the QUIP programme that I'm going to talk to you about today, which is about improving quality and driving down cost, is the safety work. So I led the national programme for the safety work. And when I came into post, what was fantastic was that I was not starting from a standing start. We had already had a decade of safety improvements that were happening nationally and regionally and locally. So people were already doing this, and anyone who's ever tried to start something new will have had the same conversations that I was having, which is, we're already doing this. So what we really needed to understand was, how do we turn this, which is the response I got from some people when I walked in and said, oh, we've got an opportunity to do something about safety nationally. Literally people sat with their heads in their hand and said, oh no, not another initiative. What was even better was when we started to talk about measurement, and then people really got even further down into a sort of fetal position. So the big question was, what do we already know and how can we add value? And Jonathan's report, and the report that Charles has written, sort of does walk you through in a very nice way the available sources of data for safety. And it's true to say that we have data in our administrative systems, we have data from audit, we have data from reports of horrible things that have gone wrong that we call incidents. And so we've got lots of data. In fact, we're swimming in it. But the question was, what does it all mean? What are the big things that we really all need to focus on in order to drive forward quality and drive down cost? And I was really interested in Jonathan's report. He talked about the things that need to be reliable across the whole system. So there are some things that happen that are really quite localized. You know, they're to do with reliability within a microsystem. And there are things that happen because actually the entire system gets it wrong. So we were really interested in those things. And what we realized was that there were actually 4 things which, when you looked at them collectively, were actually affecting over 200,000 people a year in England. So 4 things that accounted for a significant amount of the harm. We didn't know exactly how much, because the data sources, whilst plentiful, were often incomplete. So we were extrapolating information about what does this mean, in particular about the cost of the care we were delivering. And for any of you that are from an engineering background, essentially what we were looking at here are safety issues as defects in the system, which really shouldn't be there. So what did we do? We focused on 4 things. We focused on pressure ulcers, falls, urinary infections in patients with catheters, urinary catheters, and VTE. Why did we do that? Because we'd identified them as common, high-volume harms. Were they on the radar in 2010 as things that were safety issues? In some places, but not all. So what we needed to do is we needed to get people to share with us a common purpose. And I don't think you can underestimate, even if you're thinking about setting up a measurement system, how actually hearts and minds are a critical part of the equation. And for us, we knew that actually what we wanted to do was 3 things. We wanted to get people interested in these issues. We wanted to get them to start to think about what they already know and use it. And we wanted to get them to really feel passionate about changing it. So, there's an interesting thing about these things, and that is that when you start to sort of draw down on who is affected, they affect a common group, the old, the vulnerable. And also, when you start to look at them, you realise that actually, if you're old and vulnerable, you are susceptible not only to 1, but often to 2, 3, or even 4 of these harms. So they're affecting the same people, and it's often the same biological drivers that will result in 1 or more of these things happening to you. So, we set off to try to change things. And what we learned was unbelievable. So people said to us, we have to start showing this. We have to talk to the patients that we work with. We have to be open and transparent. And I work in Salford Royal. It's an organisation that I'm incredibly proud of. And one of the spontaneous things that happened at Salford Royal was that they made a commitment to their patients to go around every patient who was flagged as having a pressure ulcer and take a photograph. And they put together a slide deck to just show people exactly how much harm there is and how it affects people. And I think that there's one thing I would say about measurement. Measurement for me is not about the numbers. The numbers are a byproduct. It's about calling people to action, getting them to pay attention, and using the information to do what they absolutely want to do, which is to deliver everyday care that is over and above what they're required to do as a minimum standard. And so off we went, In 2011, it's fair to say that I think if your measurement systems are disconnected from your change programs, you're in trouble. Because actually what you need to do is you need to ensure that your measurements are happening, but that your change programs are there for people to go to once they're ready and they understand that change needs to happen. And that's a process that people walk through. Harm-Free Care up above has a website which anyone can go to, and the materials are freely available for anyone to use, and you can walk through the Harm-Free Care programme. I'm not going to talk about that today, that's another presentation in its own right. But I think one of the things that I mentioned at the beginning is this thing, the safety thermometer. And up here I put launched. I shouldn't have put that. That's not the right word. What I should have put is, we had a pilot instrument, and it took us a year to get that pilot instrument used and tested and refined, and the process that we used for the development of that instrument was essentially large-scale PDSA, Plan, Do, Study, Act testing. Some people loved it, and some people hated it, because they wanted it to be done and ready and usable and final. And that wasn't the approach that we took. So it's interesting about, what were we doing? What were we testing? Well, I'll tell you what we were testing. We were testing the operational definitions. Because what we learned was that a pressure ulcer to me in Salford, where I count my pressure ulcers every day on every patient, is quite different from a pressure ulcer to somebody down the road who does a midnight census once every 6 months. And actually, even the grading scales that we use to assess pressure ulcers differ from one organisation to the next. So the big question was, can we agree what a pressure ulcer is and how we're going to measure it? And can we articulate that as a nation? I have to say, we're still in that conversation 3 years later. This is one of the hardest things I have ever done in my entire career, and I've done some tough stuff. This is hard stuff. 2 big lessons I would share with you is, 1, listen, because people aren't shouting for no reason. But 2, push through. Don't let it paralyse you. If you can't get the perfect operational definition, go for a compromise position. Get something that is good enough so that you can get moving and move forward. Time was a constant challenge. So I was talking to Bob earlier about this particular design principle. When we had our steering group, we said we want something that can be actually delivered by a frontline clinician in less than 10 minutes per patient. Because we were hearing again and again and again, measurement is waste. We see no value in using clinical time for measurement. Now, culturally, I think we're starting to change. I personally believe that measurement is part of being a health professional. It's part of your duty of care to understand what's happening with your patient. We're on a journey, I think, but we agreed to honour this 10-minute rule. We also agreed to say, well, we will collect just enough data to be able to signal what the national trend is in these particular indicators. But if you locally want to collect information on every patient every day, go off and do it. That's absolutely fine. Frontline teams doing the assessment. So what we found was that when we presented teams, this will never have happened to you. When we presented teams with data that had come out of the administrative system, they went, that's rubbish, that's not my data. So getting ownership of the data was absolutely key. And so one of the ways we did that was to try to get frontline teams to collect and use their data themselves. Now, obviously, what you accept when you take this approach is a wide variation in the interpretation of the agreed operational definitions. So what you don't do when you take this approach is take the first 3 months' data and say, so this is how it is then. Because you know that you're entering into a learning process. Now, really important, I think, for us, and something that we're not actually yet fully signed up to, is that we know that the care system we will have in a decade's time is not the one that exists today. So we have quite a hospital-centric NHS, where people come to the hospital to be treated. But things are changing, and much more care is being delivered digitally, much more care is being delivered closer to the patient's home in the community. What's very scary is we know virtually nothing about safety outside of hospitals. And I don't think we're unusual in that respect. I think most countries would, if they looked hard enough, find that they had that challenge. So we knew that despite the fact that all of the energy and the resistance and the support was coming from the hospitals, that we had an opportunity here to start to measure wherever the patient happened to be. The care home, their own home, a community clinic. We wanted to go there with this instrument and find out what was happening. So this was it was a leap into the dark, complete leap into the dark. Here's what we did nationally. We decided that we would essentially, oh, that's all going funny. Anyway, we decided that we would take 1 day a month, we would survey 100% of patients receiving care on that day, for the 4 things that I've just mentioned to you, and that we would collect information on the proportion of patients with that thing. In total, there are around 15 indicators in the safety thermometer, which you can look at in different ways, but they're all presented as data over time. And we have been very, very clear that really the only purpose for this instrument is to look at yourself over time, not to make comparisons between hospital A and hospital B, or institution A and institution B. So here's what we're doing. So, what did we learn? Well, we worked for a year. Do you remember we were in an improvement programme? And what we learned was we asked people to give us their data. Some did, some didn't, some sort of did. So we had this really patchy participation in the programme. So we have an opportunity in NHS England to use a system called CQUIN, which is the Commissioning for Quality and Innovation programme. It's a programme that was established following a review of our health system by Lord Darcy. And we use it to actually say, right, okay, if you do this, which is over and above what we expect you to do right now, we will provide some incentive, financial incentive for that. So we thought, well, it would be a good idea to incentivise organisations to collect the data. And for anyone who's worked with pay for performance, you will know that that brings all manner of new conversations to the table. It brings a whole new literature to the table about how people are rewarded and incentivised, and whether that's a good thing, which some believe, or whether it's not a good thing, which others believe. Nonetheless, we decided to move forward with collection of data, with the establishment of data collection systems as a national programme in England in 2011. So what happened? Well, by the end of the year, we had surveyed collectively 1.8 million patients. Wow. So how impressive is that? That's all those people out there on that 1 day a month going looking at patients, having a conversation with the patient about harm, potentially creating conversations within clinical microsystems about what are we seeing, what are we finding. Some of the most powerful information we've got is about people who, having done the survey on a given day, have said, we have to do something about VTE risk assessment. Or Jack over there must have another mattress because that one isn't good. He's a high risk of pressure ulcers. So we know that action is being taken. And in fact, there are some really, really positive things that have come out. We've started to look at the data. I can tell you the headlines are that basically 12% of patients surveyed have one or more of these harms. When we looked at pressure ulcers, this is just one example, 7% of patients surveyed had a pressure ulcer. This was absolutely in the space we expected. 72,000 patients a year in NHS England. We started to use the data to let people understand. So this is a typical data report that went to senior leadership. This is I just picked a month out, where we could actually start to say, well, where is the problem? So this is the category of pressure ulcer. And what we found was that we'd thought the problem was 3s and 4s, and in fact we learnt that the problem is in category 2, which we wouldn't have measured if we hadn't have started to do this. There's no such thing as the perfect measure, and I would caution you against anyone who comes along and says, we just want one measure of safety. We learnt that. We learnt that this is not about one man or one person, and that actually the most powerful people in this, senior leaders, we've got Lloyd Provost up here, but the patients and the staff who actually do the work are the most powerful people. In 2013, we're moving from just collecting data to incentivising organisations to improve. And the indicator that we've selected is pressure ulcers. There's guidance out on the website about this. But suffice it to say, we've had to take a very careful approach to step one, getting people to review the data that they've already got and look at its quality. Step 2, getting an agreement about, so where are we at then? What's the baseline that we're working from? Step 3, looking at the national context. Are we unusual? Do we seem to have something different going on here? And if so, what would explain that? Is it case mix? What is it? What's the difference? And then thinking about an improvement goal. What's possible? What can we achieve here? Is it 5%, 20%, 30%, 50%? What's the margins of avoidability around these harms? And then finally, how do we monitor improvement? Why is that important? That's important because actually in the real world, this is what the graphs look like. They look like this. They are not easy to interpret. It is not easy to make a black and white judgment about whether we've improved or not. So what I wouldn't want you to go away with is thinking that this is all about collection. My personal view is that the bigger job is about buy-in and use. And we get completely hamstrung in the collection space, and we need to get out of it. In 2014, we're moving to a much more evaluative phase. So we've started to put ethnography into centres to actually look at how people are collecting data. And we started to think about what of this we need to publish. So there are already 2 publications in the pipeline, and there'll be several more. And thinking about other conditions that are not necessarily within the current safety thermometer, which is being called the classic, like what happens in mental health, what happens in medication safety, and what happens in labour and delivery. High risk safety areas where a temperature check might be useful, but not as a replacement for anything that we've currently got. I just want to say, one of the things that I've been cautioned to do is to find the unintended consequences of the work that I do and understand them. So there's a gentleman called Goodhart, who was an economist, I believe, who said, every time you make something a national measure, you create unintended and subversive behaviours which you have to understand. And we need to do that. But we also need to understand the good stories about the things that are happening that would never have happened if we hadn't done this. And the final thing I would say is, the one thing I've not mentioned is that for me, the power of measurement is not in arguing the toss about one data source or a different data source. It's in using it to celebrate the success that we've got. If the data aren't on the walls with the certificates being used to really incentivize people, they are worthless. So thank you very much.